Hello there. So now we have a case here of a 75-year-old man who presents with difficulty in swallowing both solids and liquids. While he admits to have mild, more bearable difficulty in swallowing for the past 3 years, his symptom has worsened over the past 2 weeks. He has been unable to eat or drink since yesterday despite maintaining a good appetite. He was diagnosed with esophageal cancer 1 year ago, which had metastasized to the liver and lungs. Additionally, there is weight loss of 2 kg since the time of diagnosis. Provided the stage of cancer and the age of the patient, surgery was not a feasible option. Now he understands the implications of his diagnosis, wishes to live in comfort for the remainder of his time. So, which of the following is the most appropriate management? So, in this case, the appropriate management is endoluminal stenting. Now, the question assesses one's understanding of palliative care. The two key points provided in the patient's history are his unimpaired appetite. So, his appetite is absolutely normal, as well as an insignificant amount of weight loss. So, weight loss is 2 kg since the time of diagnosis, which is not very significant. Additionally, he wishes to remain comfortable, and these wishes must be respected. Now, esophageal stenting is the most viable option as it provides immediate relief, which not only allows him to swallow with ease but simultaneously it also allows him to maintain his nutritional status without the need for more invasive procedures such as nasogastric tube or PEG, that is percutaneous endoscopic gastrostomy tube insertion. It is undoubtedly the most comfortable of all the options and is well in line with his wishes. So esophageal stenting can also be done. It is actually the most viable option here, and it is more preferable as compared to other invasive procedures like nasogastric tube, NG tube, or PEG, or percutaneous endoscopic gastrostomy. Therefore, it is the most comfortable of all the options, and it is also well in line with his wishes. Now, stenting is the first line option to aid in swallowing. Stents work by maintaining the patency of the esophageal lumen at the site of obstruction. Percutaneous endoscopic gastrostomy tube insertion is more suited for patients who have had a stroke or who are at risk of aspiration of gastric contents. If there is a risk of aspiration of gastric contents or who had stroke, in those cases, PEG or percutaneous endoscopic gastrostomy tube insertion is more suitable. Now, radiotherapy may undoubtedly reduce the tumor bulk and provide long-term symptomatic relief. However, an account of the lag time between initiating radiotherapy and the patient experiencing results, it would not be a favorable method of management by itself. So radiotherapy may undoubtedly it will help in reducing the bulk of the tumor and it provides long-term symptomatic relief. However, on account of the lag time between initiating radiotherapy and the patient experiencing results, lag time is more in that case between initiating the radiotherapy and the patient experiencing results. So that would not be a favorable method of management by itself. So let's further read a little more about esophageal stent. So esophageal stent is a tube placed in the esophagus to keep a blocked area open so that the patient can swallow soft food and liquids. These esophageal stents may be self-expandable metallic stents, or these are made of plastic or silicon. These are used primarily in palliative cancer treatment. Esophageal stent is a tube placed in esophagus to keep a blocked area open so that the patient can swallow soft foods and liquids. Esophageal stents may be self-expandable metallic stents, or these are made of plastic or silicon. These are used primarily in palliative cancer treatment. Okay, that is about esophageal stent. So two key points in this question are unimpaired appetite and insignificant weight loss, and the patient wishes to remain comfortable, which must be respected. So in that case, esophageal stenting is the most viable option, as it provides immediate relief, and which not only allows him to swallow with ease but also helps in maintaining the nutritional status without the need for any invasive methods such as NG tube, that is nasogastric tube, or PEG tube insertion, that is percutaneous endoscopic gastrostomy tube insertion. So it is the most comfortable option, esophageal stenting. Stenting is the first line option to help in swallowing, to aid in swallowing. These stents work by maintaining the patency of the esophageal lumen at the site of obstruction. PEG tube insertion is usually done in patients who are at risk of aspiration of gastric contents or who had stroke earlier. Radiotherapy definitely helps in reducing the bulk of the tumor and provides long-term symptomatic relief, but the lag time between initiating radiotherapy and the patient experiencing results is not a favorable method that way. Here, let's move further now. Now we have a 22-year-old man who is seen in the emergency department. Let me first go through if we have a chart on this. Esophageal stent. Okay, now read about let's go to the next case. So here we have a 22-year-old man who is seen in the emergency department with shortness of breath and abdominal pain. He has been experiencing bloody diarrhea over the past week. He has a background of ulcerative colitis. An ECG is performed which shows normal sinus rhythm. His temperature is 39.1 degrees Celsius, heart rate is 100. X-ray of chest and abdomen is given. Now, most likely diagnosis is being asked. So here we have a case of toxic megacolon. This toxic megacolon is caused by ulcerative colitis. Ulcerative colitis is the most common cause of toxic megacolon. In the abdominal X-ray here, the transverse colon is extremely dilated with loss of normal haustral folds called lead pipe colon. The transverse colon is extremely dilated in toxic megacolon with loss of normal haustrations or normal haustral folds, leading to a lead pipe colon appearance. Fever, abdominal pain, tachycardia, these are all features of toxic megacolon. Shortness of breath occurs in patients who are septic as there is an increased demand for oxygen. He needs to be treated immediately with IV corticosteroids and IV fluid replacement. So, so in toxic megacolon, our main focus should be on the transverse colon, which is extremely dilated, and ulcerative colitis is the most common cause of toxic megacolon. In the abdominal X-ray, the transverse colon is extremely dilated, and there is loss of ostrations, haustral folds, leading to a lead pipe appearance. Fever, abdominal pain, tachycardia. Fever, abdominal pain, and tachycardia. These are all features of toxic megacolon. Shortness of breath can also occur in patients who are septic, as there is increased demand for oxygen. This patient needs to be treated immediately with intravenous corticosteroids and IV fluid replacement. So now let's move further. Let's see if we have a chart on this. Okay, let's move further now. Now we have a 42-year-old man with type 2 diabetes presenting with fatigue and shortness of breath. He is noted to have a bronze tinge to his skin. Abdominal examination reveals hepatomegaly. His blood tests show a high ferritin level. Diagnosis has been made, but he is refusing the treatment. Which organ is most likely to be at the risk of developing cancer in this case? So the patient is having type 2 diabetes presenting with fatigue and shortness of breath. And he is also having bronze tinge to his skin. An abdominal examination is revealing hepatomegaly, having a high ferritin level. But the patient is refusing any treatment. So the organ which is affected here is liver. The diagnosis is hemochromatosis. Liver is a primary storage area for iron. Now here blood test shows a high ferritin level and there is bronze tinge to his skin. Now liver is a primary storage area for iron and it will naturally accumulate excess iron because it is the main storage area for iron. So whenever there is excess iron in the body, it will naturally get accumulated inside the liver. Over time, the liver is likely to be damaged by this iron overload, leading to cirrhosis. So cirrhosis and hemochromatosis together will increase the risk of hepatocellular carcinoma. So this is a case of hemochromatosis in which there is excess iron in the body. Now, as liver is the primary storage organ for iron, primary storage area for iron in the body, therefore, whenever there is excess iron in the body, it will naturally accumulate in the liver. Over time, the liver gets damaged by iron overload, leading to cirrhosis. And also, we need to remember that cirrhosis and hemochromatosis, both of them increase the risk of hepatocellular carcinoma. Now, let's read about hemochromatosis. Hemochromatosis. Now, hemochromatosis, hereditary hemochromatosis, is an autosomal recessive genetic disease in which increased intestinal absorption of iron causes accumulation in tissues, especially the liver, which may lead to organ damage. Other organs which may be affected by iron deposition includes pancreas, joints, heart, skin, and gonads. So, hereditary hemochromatosis is an autosomal recessive genetic disease. It is autosomal recessive. And in this, there is increased intestinal absorption of iron, leading to accumulation in tissues, especially liver, leading to organ damage. Other organs which are affected are pancreas. Other organs affected by iron deposition are pancreas, skin, heart, and gonads and joints. Main is liver. Other organs affected are pancreas, joints, skin, heart, and gonads. Presentation: early diagnosis is difficult because hemochromatosis is often asymptomatic until the later stages of the disease. Symptoms usually last between ages 40 to 60, usually start between the age of 40 to 60. Initial symptoms are usually very vague and non-specific, such as fatigue, weakness, and heart problems. Hemochromatosis may be diagnosed incidentally following abnormal serum ferritin levels or LFTs. Symptoms of advanced disease: it includes diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, cardiac disease such as arrhythmias or cardiomyopathy, neurological or psychiatric symptoms such as impaired memory, mood swings, irritability, and depression. So, symptoms of advanced disease are diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, cardiac disease such as arrhythmias or cardiomyopathy, neurological or psychiatric symptoms such as impaired memory, mood swings, irritability, and depression. We have to remember the triad of diabetes, hepatomegaly, and bronze pigmentation. Diabetes, hepatomegaly, and bronze pigmentation. This is seen in 30% of the patients with hemochromatosis and is a common presentation given in the questions. So, if both parents are carriers, what is the chance of the child having the disease? 25% because it is autosomal recessive. So, hemochromatosis, it is an autosomal recessive genetic disease in which there is increased intestinal absorption of iron, leading to excessive accumulation in tissues, mainly liver, which leads to organ damage. Other organs or other areas which are affected by excessive iron overload, excessive iron accumulation are pancreas, joints, skin, heart, and gonads. Presentation: early diagnosis in hemochromatosis is difficult because it is often asymptomatic only until the later stages of the disease. And symptoms usually start between ages 40 to 60. Symptoms usually start between the age of 40 to 60. The initial symptoms are very vague, general, and non specific, such as weakness, fatigue, and heart problems. Uh, this problem of hemochromatosis may be diagnosed incidentally following, for example, if serum ferritin level is high or LFTs are abnormal. Now, the symptoms of advanced disease. The symptoms of advanced hemochromatosis include diabetes, hepatomegaly, bronzing of the skin, cirrhosis, arthropathy, cardiac disease such as arrhythmias or cardiomyopathy, neurological or psychiatric symptoms such as mood swings, irritability, impaired memory, and depression. Now, the triad, we have to remember a triad in hemochromatosis, that is triad of diabetes, hepatomegaly, and bronze pigmentation. Diabetes, hepatomegaly, and bronze pigmentation. Diabetes, hepatomegaly, and bronze pigmentation. This is a triad of hemochromatosis, which is seen in 30% of the patients and is a common presentation. If both the parents are carriers, then the chances for the child to have the disease would be 25% because it is autosomal recessive genetic disorder, genetic disease. Now, let's move further. Now we have here a 38-year-old man who has just returned from Kenya a few days ago. Since his return, he has developed watery diarrhea with crampy abdominal pain. What is the single most likely causative organism? Now, the most common organism which causes travelers diarrhea is E. coli. It will usually cause a mild self limiting diarrhea for less than 72 hours. So, this is a classical question. The most common organism which causes travelers diarrhea is E. coli. It will usually develop a mild self limiting watery diarrhea. Mild self limiting diarrhea for less than 72 hours. It will occur for less than 72 hours, for less than 3 days, let's say. Giardia can be another option, but it's a type of parasite which causes a diarrheal illness called giardiasis transmitted by fecal route. Diagnosis by stool sample investigation. Metronidazole is the first line treatment. Shigella is a gram-negative non-spore forming rod generally related to E. coli. Shigella infections are shigellosis, typically resulting in dysentery, leading cause of bacterial diarrhea worldwide. Salmonella is a gram-negative enterobacter and is an important cause of diarrheal disease, salmonellosis. Severity of the disease depends on the serotype of salmonella involved. Non-typhoidal serotypes invade the GIT, leading to diarrheal disease, whereas typhoidal serotypes invade the bloodstream. And typhoidal invade the bloodstream, secrete endotoxin, resulting in severe systemic illness. Let's move further. Now we have here a 55-year-old man who has had new onset jaundice, epigastric pain, which started a week ago. He has started feeling nauseous with vomiting 2 days ago. He has no history of weight loss. He drinks an average of 35 units of alcohol a week, has done so for several years. There is epigastric tenderness with no abnormal masses on palpation of his abdomen. Bilirubin is 89, ALT is 238, ALP is 899, AST is 55, GGT is 490, albumin 36, amylase 399. More than 50% of his bilirubin is conjugated. Observations are within the normal limits aside from the temperature of 38.3 degrees Celsius. Now here we have to understand two things. First is choledocholithiasis and second is LFTs, that is liver function tests. These two things we have to understand here. Before that, let's just go through this chart of Hereditary hemochromatosis. It is an autosomal recessive disorder causing increased absorption of iron, resulting in iron overload. Presentation is arthropathy, bronze skin. These are presentation of advanced disease. There can be arthropathy, bronze skin, hepatomegaly leading to cirrhosis, leading to hepatocellular carcinoma, cardiac arrhythmias or cardiomyopathy, neurological symptoms such as impaired memory, depression, irritability, endocrine symptoms, diabetes, impotence, amenorrhea. Investigations which are to be done here include transferrin saturation, which would be high, serum ferritin would be high, genetic testing of HFE gene, and treatment is by phlebotomy and liver transplantation, cirrhosis, in cases of cirrhosis. So, hereditary hemochromatosis, autosomal recessive disorder causing increased absorption of iron, resulting in iron overload. Presentation would be arthropathy, bronze skin, hepatomegaly leading to cirrhosis, leading to hepatocellular carcinoma, and cardiac symptoms such as cardiac features such as cardiomegaly or arrhythmias, cardiomyopathy or arrhythmias, neurological symptoms such as impaired memory, depression, irritability, endocrine symptoms such as endocrine conditions like diabetes mellitus, impotence, amenorrhea, investigation serum ferritin level, genetic testing of HFE gene, and transferrin saturation. Treatment is by phlebotomy and liver transplantation in case of cirrhosis. Treatment is liver transplantation in case of cirrhosis and phlebotomy. And the triad which we have to remember is diabetes mellitus, hepatomegaly, and bronze skin. Serum ferritin level would be high, transferase saturation would be high, and genetic testing HFE gene. And treatment is by liver transplantation phlebotomy. That is about hereditary hemochromatosis. So in a while we'll continue with further topics like cholelithiasis and liver function tests.